Welcome to Learning Thursdays. As you can see, they are offered to professionals in our field as a free learning opportunity with the goal of improving the knowledge, skills, and perhaps attitudes of the New York State substance use disorder treatment workforce as we strive to improve the lives of individuals in prevention, treatment, and recovery services. We ask anytime if you have questions about Learning Thursdays to feel free to send them to learningthurs@oasas.ny.gov. The presentation you're about to experience today is Ending the AIDS Epidemic. It is hosted by the OASAS Division of Practice Innovation and Care Management with Zoraida Diaz, as well as Kelsey Louie, who is the CEO of the Gay Men's Health Crisis. That being said, I would like to turn the presentation over to Zoraida, who will introduce Kelsey. Thank you and enjoy.
Thank you, Patty. The Division of Practice Innovation and Care Management is happy to host this training on ending the AIDS epidemic in New York State. We at OASAS know the importance of addressing HIV and AIDS within the treatment system, and our goal is to continue to educate you and bring you new and innovative information so that you may deliver the best informed care. Through the years, OASAS has worked collaboratively with the New York State Department of Health, the AIDS Institute. We have made sure our treatment providers have health coordinators, which assure the provision of education, risk reduction, counseling, and referral services to all patients regarding HIV and AIDS. Now, OASAS is happy to continue our work and bring you a leader in the field with in-depth knowledge of Governor Cuomo's Blueprint Initiative. It brings me great pleasure to introduce Kelsey Louie, the CEO of GMHC.
Thank you, Zoraida. My name is Kelsey Louie, and I'm the proud CEO of Gay Men's Health Crisis, and I'm so happy to be here to talk about ending the epidemic and the New York State plan to do so by 2020, a plan that was endorsed by Governor Andrew Cuomo himself. So today I'm going to run through a few things. We're going to talk about what the objectives are for this training. I'll give you an overview of the New York State accomplishments and where we are today. I'll talk about the Ending the Epidemic Task Force. I'll also talk about updates around HIV testing, linkage to care, as well as PrEP for HIV. I'll finally talk about the recommendations, the actual recommendations from the blueprint to end the epidemic in New York State by 2020. And finally, I'll talk about the community's role in ending the epidemic. So let's start off with the objectives. So by the end of this webcast, I'm hoping that you'll be able to recall trends in HIV and AIDS epidemiology that demonstrate New York's history in successfully reducing morbidity, mortality, and new infections. You'll also be able to define our goals with regards to ending the epidemic. You'll also be able to describe the individual and community benefits of early initiation of treatment for HIV. You'll also be able to describe the scientific basis of HIV treatment as prevention. Recall developments in program and public health law to promote HIV testing, linkage to care, and viral suppression. You'll also be able to define the role of PrEP as a biomedical intervention. And finally, you'll be able to recall, hopefully, how New York State will evaluate its progress towards ending the epidemic in 2020. So let's start with the overview of New York State's accomplishments. So we've made a lot of accomplishments in New York State. One of the first and most important things to talk about is the fact that in 1993, there are more than 14,000 new cases of HIV and AIDS. And in 2013, in New York State, there are only about 3,000. So we're making significant progress. If we look at the deaths attributed to AIDS, in 1994, there were approximately 10,000. Going forward in 2013, there are less than 2,000. In New York State, we were also able to reduce new infections among injection drug users by 96%. We also decreased new infections over the last decade by 40%. And in 2013, New York State met the CDC criteria for elimination of mother-to-child transmission of HIV. It's defined as having less than one case of transmission per every 100,000 live births, and infants born to women living with HIV became infected in fewer than 1% of these cases. So we've updated our HIV treatment guidelines. In January 2014, there was guidance that we should offer all patients antiretroviral treatment, or treatment for HIV. This was based on 4 concepts. 1, that HIV treatment is very effective. 2, HIV treatment regimens are now easy to handle. 3, there are very few side effects, and when there are some, they're very manageable. And 4, early treatment reduces transmission of HIV to uninfected partners. So you'll see that we made a lot of progress over the last several years. However, we do have some ways to go. So this year and last year, some of the key dates around the governor's plan include in 2014, June of 2014, Governor Cuomo announced a 3-point plan to end the AIDS epidemic in New York State by 2020. That was a very exciting time for all of New York. In October of 2014, he convened the Ending the Epidemic Task Force. And on April 29th of 2015, he released and endorsed the blueprint to end the epidemic, and that's what we're going to talk about today. So how do we measure the epidemic, and how do we measure our goals of ending the epidemic? So one way to do that is to look at the number of new infections each year. So we're hoping that by 2020, we will reduce new infections to 750. And there's a mathematical formula that dictates that 750 is the number by which HIV and AIDS will become under epidemic proportions. And second, we're hoping to decrease the overall number of people living with HIV for the first time ever. The 3 pillars of that plan include 1, to identify people with HIV who remain undiagnosed and link them to healthcare. And what that means is making sure that we test people so that they know their HIV status. The second pillar is to retain patients diagnosed with HIV in healthcare and provide access to treatment to suppress the virus, promote positive health outcomes, and prevent further transmission. And third, to provide access to pre-exposure prophylaxis, or PrEP, for high-risk persons to keep them HIV negative. So here you see a slide that talks about the trends in HIV and AIDS cases and the progression from 1984 to 2013. There's a lot of information on the slide, including the number of people diagnosed with AIDS, as well as the number of people living with HIV and AIDS. And you'll see that over time, the number of people living with HIV and AIDS has increased over time. And you can also see that the number of new infections have decreased overall. In a few minutes, we'll talk about which parts of the population HIV infections have increased and where they've decreased. Here's another very important slide. It's the New York State Cascade of HIV Care in 2013. And this is the underlying principle of how we can end the epidemic. So we need to understand the epidemic. So we have to first understand that there are a number of people who are infected with HIV. And in 2013, that number stood at 129,000. Now we also have to know that not all of them know that they're HIV positive. So of that 129,000, 112,000, which is 87%, know that they're HIV positive. Only a small portion of that group, 86,000, are connected to HIV care. Of that group, only a portion is actually on continuous care, 74,000. So we're now down to 58%. And of that group, only 70,000 are actually virally suppressed, which means that 55% of the people who are infected with HIV are virally suppressed. So I should take a minute to explain HIV, AIDS, and viral suppression. So HIV is a virus that can sometimes lead to a condition known as AIDS. And HIV is measured in the bloodstream through the amount of the virus or viral load that's in the body. And it's also measured by white blood cells or a CD4 count. And the medication or the antiretroviral medication that someone with HIV takes is taken to suppress the virus. And when the virus is suppressed to what's called undetectable levels, it means that the person is healthy and it allows their T cells to regenerate. And T cells is a measure of your immune system. So antiretroviral medications will lead to viral suppression, which will allow the CD4s, to the white blood cells, to regenerate, and therefore you can be healthy. And later on we'll talk about the science that tells us and the studies that tell us that if someone is virally suppressed, then they are less likely to pass on the virus. So the goal for each person is to become virally suppressed by taking medication on a regular basis, which is why it's important that this slide talks about the number of people who are virally suppressed compared to those who are diagnosed with HIV. So moving to the next slide, we'll look at the number of HIV-infected infants with mother-to-child HIV transmission by year of delivery, and the progression from 1997 to 2013. So as I mentioned earlier, only 2 infants, in the year 2013, there were only 2 infants in New York State who were infected by HIV perinatally, which leaves the percentage at 0.5%. So by the CDC definition, it's been eliminated. And that was a major accomplishment for HIV and AIDS in New York State. Looking at the number of people living with HIV infections, we talked about this. By the end of 2012, there were approximately 130,000 New Yorkers living with HIV. And another accomplishment, as I mentioned earlier, is the fact that the number of new HIV diagnoses have gone down. From 2002 to 2012, the number of new infections decreased by 45%. And if we break that down into different categories, you can see that in almost all categories, the transmission rates have gone down. We will focus on one where it's gone up, but overall, they've gone down. They've even gone down among men who have sex with men. If we break down new HIV diagnoses by race and ethnicity, in 2012, you'll see that HIV disproportionately impacts certain demographics. So non-Hispanic blacks are those with the highest numbers of HIV, followed by Hispanics, and then followed by non-Hispanic whites. Again, in 2012, the total was just over 3,000 new infections. Looking at the linkage to care rates within 3 months of HIV diagnosis, you'll see that in New York State, that was about 84%. The National HIV/AIDS Strategy goal for 2015 was 85%. And you'll see that New York State is leading the way in the nation around ending the epidemic. Looking at the time to AIDS diagnosis by year of HIV diagnosis, comparing 2002 to 2011, you'll see that in 2002, 20% of the people who are diagnosed with HIV developed AIDS within 2 years. And what that means is that people were getting sick. The progression from HIV to AIDS means that people are either, and it's an old definition, but it's a definition that is still used, where your CD4 count drops below 200, or you have more than 2 opportunistic infections. So that is the definition of an AIDS diagnosis. In 2011, only 10% of the people diagnosed with HIV developed AIDS within 2 years. Again, more progress. If we look at the deaths among persons with HIV infection in New York State from 2002 to 2012, you'll see that the total number of deaths have declined. The deaths among people with AIDS have declined, and similarly, the deaths among people with HIV has declined. So, we've talked about a lot of the accomplishments in New York State, so I wanted to talk about why we are uniquely positioned to be the first state to end AIDS as an epidemic. There are exciting health system changes in New York State, including Medicaid redesign, the Affordable Care Act, and DSRIP. Over the last decade, New York State has achieved a 40% reduction in new HIV cases and significant decreases in HIV incidence across all categories of race, ethnicity, gender, age, and risk category. There was a 79% reduction in new AIDS diagnoses between 1993 and 2010. We've eliminated HIV transmission via blood products, as well as mother-to-child HIV transmission. And finally, we've decreased new HIV diagnoses due to injection drug use by 96% since the mid-1990s. So, those are all of the accomplishments that we've achieved in New York State. And much of the conversation around HIV and AIDS is the fact that while we have achieved so much, there's still a lot of work to do, including finding a cure. So some of the ongoing significant challenges in New York State is that there are 9 new HIV diagnoses and nearly 5 AIDS-related deaths each day. In 2013, out of the almost 3,000 newly diagnosed HIV cases, 72% were among gay and bisexual men and transgender women. So this is an example where HIV is disproportionately impacting certain parts of our population. More than 25% of new HIV diagnoses in 2013 were among young men who have sex with men of color, ages 12 to 29. Again, another group of the population that is disproportionately impacted. Also, 7 out of 10 new HIV diagnoses in 2012 were among people of color. Nearly 24% of people newly diagnosed with HIV are diagnosed with AIDS concurrently or within 12 months. And what that means is that people are getting tested late. They're getting tested at a time when their HIV has already progressed to AIDS. So we need to increase our testing efforts. And finally, the lack of publicly available quality HIV surveillance data sometimes can make it difficult to really attack the epidemic where it truly is. So, ending the epidemic in New York State. What it means is that there are more people living with and diagnosed with HIV, and fewer deaths are occurring among people with HIV infection. New HIV diagnoses have been decreasing. There are substantial disparities that persist among race and ethnicity, as well as risk groups. Over the last decade, decreases in new diagnoses have been seen in all groups except men who have sex with men under the age of 30. And young MSM of color have had increasing number of new infections. So that's where we stand with ending the epidemic. So I've been asked often whether or not I think, as the CEO of Gay Men's Health Crisis, the world's first AIDS service organization, whether I believe that we can truly end AIDS as an epidemic in 2020 in New York State. And the answer is yes. And I'm going to continue to tell you why. Because not only have we made a lot of advances, and we do know where we need to venture into, we have the data, and we have the tools, and we have the political will to do so. And if we work together as a community, and it starts with this training, I truly believe that we can end this epidemic once and for all. And hopefully by the end of this training, you'll agree with me. So, How are we going to do this? With the Ending the Epidemic Task Force. So earlier this year, or last year, Governor Cuomo convened a task force to end the epidemic. It consisted of 63 HIV experts and community leaders across New York State, and I was honored and privileged to be one of those 63. We held 17 different listening forums across New York State, as well as 2 phone sessions that targeted youth and young adults, with over 565 participants. And what we did is we asked for recommendations. We received almost 300 different recommendations via the AIDS Institute SurveyMonkey, the survey, from the community. So it wasn't only the work of the experts in the field, it was also the work of the community, the people on the front lines, the people infected with HIV and AIDS, different community leaders, school teachers, doctors, everybody. So this truly is a plan that was created by the people. So the blueprint that was a product of the work of the task force has 30 recommendations, 30 blueprint recommendations. And they include various steps that can be taken now to get New York State to the goal of 750 new infections per year by the end of 2020. But this group, like many groups, didn't stop there. We didn't think that 750 new infections, although that is the definition of not being an epidemic, we didn't think that that was enough. We wanted a plan that would get to zero new infections. So we created 7 other recommendations, and we called them the Getting to Zero recommendations. And they represent additional steps that could accelerate movement towards 0 new HIV infections, because that is the ultimate goal. First in New York State, then in the US, then in the world. So I'm going to now go through the 3 key recommendations of the blueprint. The first one is to identify persons with HIV who remain undiagnosed and link them to healthcare. So if you remember the cascade that we talked about, it addresses the difference between the first 2 bars, those people who are HIV positive compared to those people who know that they're HIV positive. And the only way to do that is through HIV testing. So we want to make routine HIV testing truly routine. And I'll talk about that. I'll talk more about that and exactly what that means. We also want to expand targeted testing. We want to address the fact that there are still acute HIV infections, and we want to improve referral and engagement. So I'm going to talk about HIV testing, give you some background and give you some updates as to where we are. So approximately 14% of HIV positive New Yorkers do not know their status. 30% of newly diagnosed HIV cases already have or will have an AIDS diagnosis within 1 year, which means that people tested late or months or even years after they were first exposed to the virus. And the U.S. Preventive Services Task Force recommends clinicians screen adolescents and adults up through 64 years of age for HIV. The importance of increased and earlier HIV testing: 36% of new HIV infections are in 13 to 29-year-olds in New York State. People who are unaware of their HIV positive status are more likely to transmit HIV to others. And awareness of one's HIV status affects behavior. With regards to how HIV testing laws have evolved, there was a watershed moment in 2010 where we were able to establish in New York State a mandatory offer of HIV testing as part of routine healthcare. So just like when you go to the doctor and you get a cholesterol screening, you also get an HIV screening as well. In 2014, it was further streamlined. The consent process was further streamlined for the mandatory offer for HIV testing, which makes it easier for people to receive an HIV test. Can you believe that there are actually barriers to receiving an HIV test? And a lot of that had to do with the comfort of the doctor, the comfort of the physicians being able to talk about HIV tests, to talk about sex. And we'll talk more about stigma, but stigma has a lot to do with the old HIV tests that were in effect. So luckily in 2010 there was an update, and in 2014 there was an even more, a better update. So to talk about that required offer, regulations require that an offer of an HIV test to every person happens between the ages of 13 to 64, or younger or older if there's an indication based on risk. Additional offers to HIV testing should be made for persons whose risk behaviors indicate more frequent testing. For example, people who inject drugs, or people who have unprotected vaginal or anal sex. And this is where the discernment around someone's risk comes into play. And being able to talk about one's sexual behavior and to reduce the stigma, to be able to talk about how you have sex and the things that you do, and to speak openly and honestly with your doctor is really important. So where are these required offers required to happen? In healthcare settings such as inpatient departments at hospitals, emergency departments, primary care services and outpatient departments of hospitals, as well as diagnostic and treatment centers. And that includes school-based clinics and family planning sites. So in almost every healthcare setting, they're required to offer. The required offer needs to happen. Which providers? Almost every provider, physicians, physician assistants, nurse practitioners, or midwives should be offering that HIV test. And primary care means the medical fields in family medicine, primary care obstetrics and gynecology, general pediatrics, and internal medicine. So really, this is a broad-based and broad-stroked approach to HIV testing to truly make it routine. Before the HIV test, providers must give patients key points of information about HIV so that the person can be well informed. The key points may be provided orally, by video, or in a written document. Individuals can have the opportunity to decline an HIV test. However, they should understand what that means, and it's the responsibility of the physician to help them understand what that means. The physician or the person ordering the HIV test must provide or arrange an appointment for follow-up medical care for all persons who test HIV positive. That appointment for follow-up HIV care, though the law doesn't require the specifics of the specialty of the physician, however, the appointment must be made. And the individual's medical record or file should reflect the name of the provider or facility with whom the appointment was made. So basically, there are now regulations that will ensure that if a person tests positive, that the systemic barriers are eliminated so that people can be connected to care after they test positive. Another great accomplishment in New York State in 2014 was the fact that HIV testing consent can be obtained orally. Prior to that, there needed to be written consent, and that can make it really hard, yet another barrier. In between that time when someone reads a document or hears the information about an HIV test and the time that they sign that document, not only is it a logistical barrier, but that just includes or gives somebody who may be scared, who may be fearful, who may not have a lot of knowledge, it gives them time to change their mind and not take care of themselves by getting tested, because they'd rather not know than know. So now, oral consent can happen, and that's all we need for someone to take an HIV test. Documentation of that test should be noted in the patient's medical chart. And finally, if a person refuses to take that HIV test, it should be documented in the client's chart so that the next time they go to a doctor, the doctor or the next doctor can see that there was a refusal for a test and that person has not been tested. Consent for the HIV test is valid for repeated testing, which means that once someone gives the approval to be tested, they don't have to give that approval every time they get tested. It's approved until they actually have to revoke that consent. And again, something like this allows for routine testing to be truly routine, to capture as many people as we can in terms of knowing whether or not someone is HIV positive or not. It is so important for someone to know their HIV status, because if they are, they can then take the next steps to get in healthcare, and as I said earlier, to get on a medication regimen that will keep them healthy and to keep their sexual partners healthy. And if each person gets tested, gets care, reduces their viral load, that can lead to a community viral suppression, which can lead to the ending of the epidemic. And so, again, oral notification must be provided to the person each time an HIV test is performed. So the conversation that happens after an HIV test should be tailored to the results of the test. So first of all, negative results don't have to be communicated face-to-face. That information that can be provided via mail, email, or telephone, as long as patient confidentiality is protected. Before, an HIV negative result would just end the conversation with the doctor. Today, that conversation can now include an explanation about PrEP and PEP. PrEP is pre-exposure prophylaxis, and PEP is post-exposure prophylaxis. And these are both one of the key pillars, the third pillar in the epidemic, so we'll talk about that in a few moments. The second of the three key recommendations is to link and retain persons diagnosed with HIV in care to maximize viral suppression so they remain healthy and prevent further transmission. So first, we want to use data to identify and assist patients who are lost to care or not virally suppressed. We want to enhance and streamline services to support the non-medical needs of all persons with HIV. We want to provide enhanced services for patients within correctional and other institutions and specific programming for patients returning home from corrections or other institutional settings. So let's talk about linkage to care and treatment. So in 2014, there was an update to the law that basically said that, that provided a way to capture information around linkage to care. So HIV-related information is reported to the Department of Health via a case reporting system that can be shared with medical providers in order to promote linkage and retention in healthcare. And patients may be contacted by medical providers or health departments to address barriers and to promote engagement in care. Information is still confidential, and that's important to understand. Despite this increased information sharing and access to information to the health department, individual information is still held to the strictest of confidence. And really, it's important because of all of the stigma that's attached to HIV and AIDS. It's critical that people know that their information will be confidential. So in talking about the treatment, it's important to understand that treatment for HIV and AIDS has progressed. Earlier in the epidemic, there were no comprehensive regimens available. There were significant toxicities and side effects with the medications that we had, and there was a heavy pill burden, which meant that you had to take many pills many times a day, and it was hard. Certainly hard for anybody, harder if you were also plagued with things like homelessness, mental illness, substance use issues. And so, luckily for us, current treatment has made much progress. Today, treatment is highly effective. It's easier to take. Regimens often include just one pill a day. And the side effects, if there are any, are often minimal and definitely manageable. And so treatment for HIV is much better and much more easily tolerated by the body. There are clinical guidelines on when treatment should be initiated. In 2014, the clinical guidelines were updated, and it was updated to say that people, regardless of regardless of the stage of infection or their CD4 count is, everyone should be put on medication right away. Because of studies, we understand that any viral replication or any untreated infection can lead to complications. In 2006, there was a SMART study done that had results that changed HIV treatment and led to those 2014 updates. It basically said that delaying or interrupting treatment can lead to negative health outcomes, including HIV-related complications and complications with other systems, whether metabolic, cardiovascular, or complications with the kidney or the liver. And multiple studies confirmed these findings. And what also came out of that study was the fact that maintaining viral suppression and avoiding low CD4 counts is critical to one's health. Now, this changed the face of treatment and how people saw treatment because treatments used to be harsh on the body. Many people stopped taking their medications when they were feeling healthy. And then when they weren't feeling healthy, they were starting up again. And they went through these cycles. And for a while, we all thought that that was okay. However, these studies have told us that it's not okay, and people need to stay on their medication regimen continuously. And with the idea that these medications are much easier on the body, it is more accepted by people living with HIV and AIDS. Another downside of HIV is the fact that accelerated aging happens within patients who are HIV positive. There are increases in neurocognitive issues and potentially possible damage to other organs. And so maintaining your medication regimen can mitigate these effects. And often the progression of HIV can lead to frailty, so continuous and regular treatment can stave that off as well. So we often promote positive health outcomes with the conversations around ongoing and continuous medication. It's critical to address treatment adherence with people and all of the factors that can impact whether or not someone adheres to their medication regimen. And everything ranging from real, true barriers like access to health care, access to the medication, ability to pay insurance, to things like stigma and untreated mental health issues and untreated substance use issues. We need to help people achieve and maintain viral suppression. We need to promote smoking cessation, address substance use issues, understand the importance of nutrition, and understand how nutrition can help in one's health, especially those people who are HIV positive, and how good and proper nutrition can improve one's immune system. Similarly, the benefits of cardiovascular exercise needs to be talked about because that too can boost one's immune system. And also being able to talk to people who are HIV positive about proactively managing their health. Being knowledgeable, talking to their doctors, having regular, honest conversations with their doctors. And that doesn't only apply to people who are HIV positive. All of these things that we talked about can also be applied to people who are HIV negative as well. The idea is that it is important to be and stay connected to healthcare. And it's important to have honest and open conversations with your healthcare provider. Another important study that helped advance the ideas of treatment for HIV and AIDS was the Prevention Trials Network, known as HPTN 052. But it was a clinical trial that evaluated the effectiveness of antiretroviral treatment to prevent sexual transmission of HIV. So this was a study of almost 1,800 serodiscordant couples. And a serodiscordant couple is a couple where one person is HIV positive and another is HIV negative. And in this study, the HIV-infected partner had not previously received medication and had a CD4 count of about 350 to 550. So not an AIDS diagnosis, but certainly there was some progression of the virus in the body. All participants in the study received counseling on safer sex practices. They were given free condoms and regular HIV testing and treatment of sexually transmitted infections. And there were two arms of the study. One was a group that received immediate treatment and one that received delayed treatment. And the results of this study demonstrated that people who are on antiretroviral treatment were 96% less likely to transmit HIV to their HIV-negative partners. That concept is worth repeating. People on antiretroviral treatment were 96% less likely to transmit HIV to their HIV-negative partners. Why is that so important? It's important because it tells us that treatment is prevention. The idea that someone who is HIV positive can adhere to their medication, become virally suppressed, and not pass on the virus. So one, it gives us a lot of information and confirmation of what we thought we knew, but it confirmed that piece of information. But it's also important because it can be used to reduce stigma. And I can't underscore the importance of the role that stigma plays in perpetuating HIV as an epidemic. And we'll talk more about that in the next few slides, but the idea that treatment is prevention helps people understand that if they take care of themselves, they're also taking care of the people that they have sex with, and they're taking care of their community. And again, this is how we can achieve viral suppression and truly end the epidemic. So when people are confirmed positive, we need to ensure that they are linked to medical care and that the conversations and the messages are important and emphasized that they need to be in care. So we need to emphasize the important benefits of accessing and staying in medical care right away. And because of the updates in the past few years, health departments may contact people to assist with accessing care if needed. And the health department will try to identify barriers to care and to address those barriers. Sometimes those barriers are real and concrete, like insurance issues, and sometimes they're of an emotional nature. And that's where agencies like GMHC and other service providers can really impact whether or not someone gets linked to care. And again, if we talked about that treatment cascade of people who are HIV positive, people who know that they're HIV positive, people who are linked to care, and people who stay in care. And so we've talked about that so far, and what we need to do is we need to close those gaps, because those are the people who are able to infect others, either knowingly or not, and that is how we can end this epidemic. So I keep trying to convince you that we can end the epidemic, because I do think it's important that we believe we can. Rarely can things be achieved if we don't even think we can do it. So again, I'm leading you, but I'm hoping that by the end of this training, you'll be able to understand why and believe that we truly can end this epidemic, and that you can understand your particular role in doing so. So the third key recommendation is providing widespread access to PrEP for high-risk persons and keeping them HIV negative. So I think we need to take a step back and to define PrEP and PEP. PrEP is pre-exposure prophylaxis, and PEP is post-exposure prophylaxis. And PrEP is a medication that you can take 1 pill a day, and studies have shown that it is upwards of 90 to 95% effective if adhered to in preventing HIV infection. PEP, or post-exposure prophylaxis, is a pill that you, or 2 pills a day that you can take for a 30-day regimen within 48 hours of exposure to HIV that can block the transmission of HIV to somebody. And those are really important to know about, and it's important to be able to access, especially the timing around post-exposure prophylaxis. It must be started within 48 to 72 hours within exposure to HIV in order to be effective. And both sets of medications need to be taken daily, and adherence is important. So we're going to talk about PrEP because it is one of the 3 key pillars of the plan to end the AIDS epidemic. So in doing so, we need to undertake a statewide education campaign on PrEP and NPEP. NPEP is non-occupational PEP. Non-occupational meaning all instances other than, let's say, a needle prick for a healthcare provider. We need to include a variety of statewide programs to increase access to PrEP and PEP, and to create a statewide mechanism for persons to access PrEP and PEP. And finally, to develop mechanisms to determine PrEP and PEP usage and adherence. And this is innovative for the recommendation for widespread adoption of a medication to prevent HIV is really innovative and something that New York State has embraced and is really exciting. So, pre-exposure prophylaxis for HIV. So there's a lot to know. It's relatively new and studies have been done, and it's important that we put out good and accurate information. And I'll tell you why in a minute. But here's the information. So there was an IPREC study done, a placebo-controlled study with men who have sex with men and trans women who have sex with men. And so in this study, about 1,200 people received the drug and 1,200 people received the placebo. And in the segment that received the drug, there are only 36 infections compared to 64 infections on the placebo side. And then they tested adherence. And there was a, for those people who were about 50% adherent, there was a 50% reduction in infections. And for those who were 90% adherent, almost 73% reduction in infections. And so efficacy is strongly correlated with adherence. And further studies had shown that the medication is much more effective when adhered to daily. So when we talk about PrEP, some things to understand. And so 1, it's only 1 pill a day. 2, it asks if someone is on PrEP, they are required to get regular HIV testing. In fact, they're asked to get testing every 3 months. And so having someone on PrEP promotes regular HIV testing, which is another important aspect of ending the epidemic. And the reason why it's important to get tested regularly if you're on PrEP is because if you do become HIV positive, you need another course of treatment. And we don't want someone who is HIV positive only taking the amount of medication in PrEP. We want them to be on HIV treatment. Oftentimes, the conversation around condoms is had around people with taking PrEP. The conversation comes up, does usage and promotion of PrEP, does that mean we are saying that you don't need to use condoms? Absolutely not. We are saying that PrEP is another alternative to HIV prevention. In fact, the common guidance is to use condoms as well as PrEP. However, we know that there are a number of people who are not using condoms, and so for them, PrEP is a great alternative. We also ask for periodic STD or STI screening, again, every 3 months. And that's important because PrEP is not designed to protect against the spread of other STDs. When you go to the doctor every 3 months, you can have, or you can be engaged with your healthcare provider to talk about safer sex practices and other options. And finally, there should be some type of support around adherence. So all this put together, what we like to say is that PrEP is often a gateway to healthcare. And I've already talked about the importance of maintaining good healthcare and a good relationship with your doctor. And being on PrEP will help facilitate that because you're required to go to the doctor every 3 months. So looking at the study, you'll see that those people who were on PrEP, there were fewer incidences of HIV infection compared to the placebo. So looking at the people who actually seroconverted in the study, we saw that there was a low frequency resistance testing performed. So what that means is basically we were able to see that those who seroconverted weren't as adherent to the medication. There is a detection of the presence of drug resistance, especially among the seroconverters who had lower levels of adherence. The importance of regular HIV testing to identify seroconverters was important, and patients who seroconverted, again, I mentioned earlier, should stop taking PrEP and be evaluated for an effective antiretroviral treatment regimen. So in another study, again, done with intravenous drug users, we had the same results. And so, and more, and since these slides were made, there continue to be more and more studies to look at the efficacy of PrEP. And so New York State guidelines for the use of PrEP, the guidance is to offer PrEP to gay men and trans people who have unprotected anal intercourse. It's recommended for people in sexual relationships with a partner who is HIV positive, male to female and female to male transgender individuals who are engaging in high-risk sexual behaviors, and people who have had more than one STD in the last year. So this is the guideline by New York State as to who should be offered PrEP. And really, this has changed since these guidelines have come out. Who should be offered PrEP? Basically, anybody who feels that they are a good candidate for it should be offered PrEP. And oftentimes, it depends on how one person feels. I mean, I've spoken to many different people with different risk categories, different demographics, different sexual behavior practices, all asking whether or not they should be on PrEP. And really the question that I ask back is, do you think PrEP is a good HIV prevention tool for you? How often do you use condoms? Will you continue to use condoms? And the answer hopefully is yes. People who are on PrEP should continue to use condoms. And so really it's a personal decision. However, more and more people are taking PrEP, and it's exciting to know when I see the numbers of the number of people in New York State who are on PrEP. It's exciting to see that more and more people are taking PrEP. Not enough, but more and more. Another interesting fact is in the early stages of PrEP, the group that took on PrEP more easily was women. And to many people that was surprising. However, if you stop and think about it, women are used to taking medication to protect their bodies. It was very akin to birth control. And so what we learned from the experiences of birth control can be applied to PrEP, in particular the stigma. So stigma is an issue around who is offered PrEP and who takes on PrEP. And the idea is that what does it mean if you're on PrEP? And what did it mean when women put themselves on birth control? I'll tell you what it does mean. It means that those people are deciding to take care of their bodies and to take care of their health. And that's what the decision to be on PrEP is. More guidance around PrEP is for people who inject drugs or who share injection equipment, people who trade sex for money, drugs or housing, people who use stimulant drugs associated with high-risk behaviors such as meth, and people who have been prescribed multiple courses of NPEP. And so that's a very interesting thing that we learned in this field is that, again, post-exposure prophylaxis is what you can take if you feel like you've been exposed to HIV. So when people have went to the doctor and asked to be put on PEP because they feel like they were exposed to HIV and they want to ensure that they don't become HIV positive, when someone goes on PEP several times in a year or several times in a year and a half, what it tells us is that they are engaging in behavior that they think can expose them to HIV. So for those people, it's important to have the conversation around maybe they should consider being on PrEP and taking pre-exposure prophylaxis on a regular basis. And so that's something that's new that came out and based on our experience, and there will be updates to that in the guidance, I'm sure. So I wanted to take a break to talk about what just happened very recently within the past week, and not to dispel everything that I just said in the last 15 minutes about the efficacy of PrEP. However, it's like I said, it's important that we put out good and useful information. So recently, it became public that there was somebody who, a gay man who is adherent, who had been adherent to PrEP, who became HIV positive through a resistant strain of HIV. And while that is true, medical professionals and HIV and AIDS activists and social service agencies like GMHC still promote PrEP. No one, not the studies, or no one had ever said that PrEP is that silver bullet that is 100% effective 100% of the times. No one ever said that, and we are saying that it is an effective means of HIV prevention. Put that together with condoms, and even greater chance of preventing HIV infection, and there are still many, many, many more people who are on PrEP who are not HIV positive. So the idea that while this happened once, it is still a rare case, and medical providers and experts have weighed in on that. But I just thought that it was important to keep you current with the latest information. And I'm sure there'll be more to come about that information. But till now, it's just one case, and it's still very rare. And the World Health Organization, the CDC, and the New York State Department of Health still recommend PrEP as a viable tool to prevent HIV infection. So let's talk about the recommendations from the blueprint to end the epidemic in New York State by 2020. So besides the ones that I mentioned, the key recommendations are to decrease new infections and disease progression. So we want to promote the health of people who use drugs, ensure access to stable housing, address transgender healthcare and human rights, establish an HIV peer workforce, promote comprehensive sexual health education, remove disincentives for the possession of condoms, provide Hep C testing to persons with HIV because we know about the rates of comorbidity between the two, expand and enhance the use of data, and increase access to employment and vocational services. So you'll see that there are many recommendations that are secondary to HIV infection, but we understand that there are many social determinants to HIV and that there are many social and structural drivers to HIV, that it's not just the fact that we need to address HIV and AIDS as a medical issue. We understand that there's so much more involved that perpetuates the epidemic, and many, if not all of these things, are addressed in the blueprint. We talk about high impact prevention. And high impact prevention is something that was put out by the National HIV and AIDS Strategy. It's scientifically proven to work, it's cost effective, it's scalable, and it's targeted to different populations. And the reason why, what's great about the New York State blueprint to end the epidemic is that it is aligned with the National HIV/AIDS Strategy. And so it's great that the plans are in sync and they're not contradicting each other, and that they will support each other because, like I said earlier, the goal for us is to end the epidemic in New York State first, then in the country. And if we're using the same strategies and the same tools that can be scalable, then it is a plan that can work. So some of the prevention interventions that are emphasized, they are grouped into two. Prevention with people who are HIV positive. So testing and linkage to care, antiretroviral medication, keeping people retained in care, talking about their behavioral risks and how to reduce that risk, continued STD screening and treatment, and to prevent perinatal transmission. In terms of prevention with HIV, people who are HIV negative, targeted condom distribution, again, behavioral risk reduction. We talked about PrEP and PEP, syringe access, and STD screening and treatment. And so what's great about the idea of high impact prevention is the idea that it's not just the responsibility of the person who's HIV positive, or it's not just the responsibility of the person who's HIV negative. This is a community problem that everybody has a role in solving. And it's great that there's an understanding that there are ways that you can contribute to ending the epidemic, whether you're positive or negative. And really the idea is breaking down that stigma. And there are many social media campaigns out there. Two that I know of are the HIV Equal and the HIV Smart campaigns. And it's the idea that everybody has a status. Whether it's positive or negative, everybody has a status. And it's important to be able to talk about HIV, and it's smart to know your own status. And so the more that we can do to break down the stigma that's associated with HIV, the more we can truly talk about it, address it, and solve it. So let's talk about the actual blueprint. And so during this phase, the task force met about 6 different times, and we looked at all the recommendations from the community, And we were broken up into 4 different groups. And they were treatment, prevention, housing and other services, and data collection. And so I happened to be in the prevention subgroup, and we went through a rigorous process of vetting all of the different recommendations from the community, and it led to the 30 recommendations of the blueprint and the additional 7 to get to 0 new infections. And as I said, it was an honor and such a rich experience to be sitting in the room with the 62 other experts in the field, in addition to other key stakeholders that were part of the process. And we're really proud of the recommendations because I believe they are comprehensive and effective. And so here are the recommendations. They're grouped in 4 different categories. The first one, as we talked about, belongs to the first pillar, which is identifying people who are HIV positive, who remain undiagnosed, and link them to healthcare. And so I won't go through the 30 recommendations, but you'll see it's about items are things like making routine testing truly routine, expanding targeted testing, and improving referral and engagement. So there are 4 recommendations around this, and again, that addresses that cascade of people who are HIV positive compared to those people who know that they're HIV positive. The second group were focused on that second pillar, which was to link and retain persons diagnosed with HIV in care to maximize viral suppression so they remain healthy and prevent further transmission. And some of the recommendations are things like continuously act to monitor and improve rates of viral suppression, to use client-level data to identify and assist patients lost to care or not virally suppressed, and to maximize opportunities through the statewide DISRIP process to support programs to achieve goals related to linkage, retention, and viral suppression. And so those were those recommendations, and again, that speaks to the second group of that cascade of ensuring that the people who are HIV positive are connected to care, and of that group, linked to care. And if we can close those gaps, it means that we can be mathematically ending the epidemic. The third set of recommendations is to provide PrEP for high-risk persons to keep them HIV negative. So recommendations such as undertaking a statewide education campaign on PrEP and PEP, creating a coordinated statewide mechanism for persons to access PrEP and PEP, and prevention-focused care. And with that, we considered so many different things around how to make PrEP accessible. Accessible in terms of knowledge and accessible in terms of cost. And I'm happy to say that most insurance companies and Medicaid will pay for PrEP. And so access is being granted to those who need it the most. The fourth set of recommendations are to support the decrease of new infections and disease progression. And about half of them fall under this category. And this is where we really looked at all of the different things that impact and drive the epidemic. Things like increasing momentum in promoting the health of people who use drugs, ensuring access to stable housing, instituting an integrated comprehensive approach to transgender healthcare and human rights, establishing mechanisms for an HIV pure workforce, improving access to care for residents of rural, suburban, and other areas of the tri-state of the state, promoting comprehensive sexual health education. As I mentioned, treatment as prevention information and anti-stigma media campaigns, and equitable funding where resources follow the statistics of the epidemic. I mentioned earlier, we have the data and we have the tools. And we need to use the data and the tools in order to create smart and effective programs and to increase access to opportunities for employment and vocational services. And these are all things that we know through our experience and through our work impacts the rate of HIV infection, access to care, and are some of the reasons why HIV disproportionately impacts some parts of the population. And something I haven't talked about yet, which is really exciting, are the recommendations to get to zero infections. And some of those recommendations are having a single point of entry within all local social service districts across New York State to essential benefits and services for low-income persons with HIV and AIDS. That is something otherwise known as HASA for all. The decriminalization of condoms, something that not many people know, but did you know that if you are caught carrying a certain amount of condoms, you can be convicted of a crime, and it's an indication that you may be a sex worker. And so we've had much improvement around that, and we're still working on completely decriminalizing the condoms. I mean, think about that. If there was a chance that you could be convicted of a crime because you had condoms on your possession, wouldn't that reduce the number of people who carried condoms and therefore use condoms? Which is antithetical to the whole idea of ending the epidemic, which is why that's part of the recommendations to get to zero. We also want to look at passing reforms to help ensure that people who are young have access and the right to consent to HIV and STD treatment and diagnosis and prevention. And the idea that, again, if someone is afraid of their parent knowing that they're having sex, it will prevent them from accessing good information, talking to their doctors, accessing medication that can be life-saving. And so these are some of the things that we want to address, and we think that we need to address in order to get to zero new infections. So if we look at the community's 3 zeros, we're looking at 0 new HIV infections, 0 AIDS deaths, and 0 stigma and discrimination. And we think that if we work towards these 3 goals, we can work to end the epidemic once and for all. So looking at the ending the epidemic stakeholders, and that is not just the task force, but all of the people involved, all of the people in the HIV/AIDS community, and all of you. So let's look at what we can do and our role in ending the epidemic. So let's look at key populations. The task force ensured that we prioritize the needs of key populations significantly and disproportionately impacted by HIV and AIDS, and that became a central component of the final blueprint to end the epidemic. As you can see here, you can look at the different rates of infection for different categories of people, and we've talked about race and sexual orientation, and the idea that while some strategies have worked for some parts of the population, those strategies haven't worked for all. And so we need to create new strategies to address the epidemic in different parts of the population. So what's great about this work is that it's not just social service providers, and it's not just community-based organizations, but it's also the government. It's also organizations like the AIDS Institute and the City Department of Health who are getting involved. We have a good partnership working with how our contracts are laid out. And you probably understand the idea of deliverables with contracts, and they've all been tweaked to align with the ending of the epidemic. there are new priorities and performance measures on how we use government funding to provide HIV and AIDS services. There are changes to work plan expectations. There's more flexibility, and there's more of a focus on high impact prevention. And there is a use of continuous quality improvement methodologies, ways that we can evaluate and examine our own work to ensure that we are effective in achieving these goals. And we're being asked to make data-driven decisions, to talk about how we deliver our services and how we serve our communities so that we can truly end this epidemic. So I've talked about the idea that we have the data and we have the tools and we need the political will to end this epidemic. And here are some examples that should inspire you around what's happening in New York City and New York State. So on World AIDS Day, the New York City Council announced that they're allocating $6 million to ending the epidemic. In addition to that, Mayor de Blasio, his budget included another $23 million towards ending the epidemic. And he also committed to the city's share for HACA for All, which was that first recommendation to getting to zero. And this would extend services to approximately 7,000 HIV positive people who are not diagnosed with AIDS, and to extend benefits to them. And that's really exciting because we all know how important mental health treatment and stable housing and benefits like that are critical to one's health and prevention of HIV. On the state level, $10 million was allocated to ending the epidemic work. And on World AIDS Day, Governor Cuomo announced an additional $200 million to support the efforts. And so that's really, really exciting. Forward to today, we're in conversations. The Ending the Epidemic Coalition is in conversations with the governor to ensure that that $200 million certainly gets allocated, and that it wasn't just a pledge and it wasn't just a commitment, but that he follows through with that commitment to ensure that we have the dollars to implement the programs and the policies that are truly needed to end AIDS as an epidemic. So, ending the epidemic isn't only the right thing to do, but it's also cost effective. Improved HIV health outcomes can reduce public spending. Volume-based pharmaceutical discounts will significantly reduce antiretroviral medications costs. Higher rates of viral suppression will improve health and prevent infections, and improved HIV health reduces avoidable health care spending, and each prevented HIV infection saves over $440,000 in lifetime treatment costs. So you can see that this is also cost effective and that there will be a net savings to Medicaid. And early forecasts say as much as $4.5 billion by the year 2020 if we start to make the advances as planned. And I just have to say that TAG, the Treatment Action Group, and Housing Works came up with this great fiscal study that is worth looking at. You can see the website as to how to access it, and it's a great model to look at the return on investment in this work. And for those people, for the government to need, where part of their work is to reduce spending, this is another reason why we should invest in this work now. Some of the actions that the community has taken, or that you can take, is to join the Ending the Epidemic by 2020 Community Coalition. You can join regional Ending the Epidemic work groups to establish regional targets and actions. You can always advocate for proper spending of the budget with the New York State Legislature. You can call upon legislative action to advance the blueprint. And you can call upon New York City and New York State to work together to jointly fund the swift implementation of HASA for all. And those are just some of the things that you can do. This is a list of the organizations and the groups that are part of the End AIDS in New York State 2020 Community Coalition, and it's a lot of groups, and you can see that. And some of the things that we are currently doing that many organizations on this slide are doing is we are re-examining our work and making sure that our goals are aligned with the goals of the state plan to end AIDS, which in turn is aligned with the national HIV/AIDS strategy. And so we're doing that within our organizations, or many of us are, and I can tell you Gay Men's Health Crisis certainly is. What we're also doing, which is unprecedented, is we are looking at where we aren't able to implement things in the blueprint, and we're finding partners who can help us do so. So one example is that the LA Forney Center and GMHC, we are working with ACT UP, and together the three organizations are working together to figure out how we can address the problem of young LGBT homelessness. And you know, it's not one of the primary services that we offer at GMHC, and it's not one of the primary services of ACT UP. However, our two groups, along with the LA Forney Center, are working together to see how we can tackle this problem, because it's one of the recommendations in the blueprint. And that is just one concrete way that organizations can advance the work of this blueprint and truly end this epidemic. And so I'm hoping that something like that, an example like that, will help you think about ways you can go back to your organization and to think about what you can be doing, what your department, what your organization can be doing to truly end this epidemic. And I'm hoping that, you know, with this training, you not only learned a lot about HIV and AIDS and HIV testing and the importance of linkage to care and PrEP and PEP, but I'm hoping that, if nothing else, you're walking away with some inspiration or a reminder that HIV, while it's no longer a death sentence, it's still a problem that we as a community have to face. And so I'm hoping that you can walk away from this with a renewed sense of commitment to doing the work that you do, understanding the impact of your work on the ending of the epidemic, and with a renewed sense that while there is a lot of work to do, this is something that we can achieve, but we have to work together. So thank you for your time, thank you for your attention, and it's been an honor for me to deliver these messages and to talk to you about the work that we're doing to end this epidemic. Thank you.
This is Patty Corbett Ward again, and at this time I would like to thank both Zoraida and Kelsey for bringing us both an informative and extremely current and up-to-date presentation on ending AIDS in New York 2020. I also would like to thank all of you for joining us for this presentation, as it is probably the first one that is being presented in the new Learning Thursdays format. As always, we appreciate your feedback, and I ask if you would take a moment, please, and complete the survey that can be accessed at the SurveyMonkey link that follows. We ask for your feedback. It's one way for us to determine that we are meeting the learning needs of the substance use disorder treatment field, the professionals. At this point again, thank you for joining us, and we will see you again in April.